Hello, viewers. My name is Tuyeimo Haidula, and I am bringing you a documentary on comprehensive sexual reproductive rights in Southern Africa. The documentary will look at 3 countries, that is Namibia, Botswana, and South Africa. I take you on a tour on what happens in 2 of Namibia's biggest hospitals, Katutura and Windhoek Central Gynae wards, and how our healthcare workers offer the much needed support to the patients. The nurses talk about cases of botched abortion, which are also presented at the hospital. Many a times, the question remains, why are these women seeking for these services? What has government not done prior? I pursue this story to identify and prioritize needs and potential follow-up actions related to critical sexual and reproductive health issues, specifically the reduction of unintended and unwanted pregnancies, the unmet need for contraception, morbidity and mortality related to the unsafe termination of pregnancy, and the integration of HIV and sexual and gender-based violence. I pursue this story to look at areas where Namibia can improve on health for all and gender equality, and the African Union's Agenda 2063 to improving sexual and reproductive health in Africa, particularly among adolescent girls and youth women. The African Union's Maputo Protocol, the protocol to the African Charter on Human and People's Rights on the Rights of Women in Africa, is the only human rights instrument with prescriptive language on abortion criteria, and estimates that the Maputo Protocol contributed to countries' reforms that added legal grounds regarding abortion since its adoption in 2003. I pursue this story for a young woman out there who might have accidentally fallen pregnant, a victim of rape, or women who may find themselves unexpectedly pregnant and very scared to know that they too can have an abortion and that life and football will go on. I've spoken to industry experts on the issues of comprehensive sexual reproductive rights, including our former First Lady, Monica Gengos. They all carry a strong message of advocacy based on the evidence of the impacts of sexual and reproductive health and rights issues. There's a call for the need to delay sexual activities in young people and provide greater care for the women, youth, and adolescents, rights for control and free decision-making on matters related to their sexuality. Maria is now a beauty therapist, a retired sex worker. She aborted when she was 32 years old. She is now 39, turning 40. She had just separated from her husband for a year, and she had 3 younger children. She was also not sure who fathered her pregnancy and the relationship status, if at all. So termination was the only way out for her. She scrolled for numbers on social media and found a seller who sold her 4 pills, but it didn't work. She called the seller again and she was informed she needed a double dosage. Maria paid and waited. Maria's nightmare began when the pain was excruciating. She had no choice but to seek medical care at a private hospital. There she laid out her truth and she told the nurse on duty what she had done. She was later to discover that she was pregnant with twins.
First I was prepared. I had made a choice, which was circumstantial then, that I'm going to have this abortion. But the moment I learned that I was actually carrying double, like 2 babies, that really hit me so hard. I felt like I just wish I could turn back the hands of time. It really, it really hit me so hard.
My name is Sister Mujanima. I'm a gynecologist nurse. Welcome to 2 West. This is a gynecology department. This is our procedure room. We usually conduct MVA. MVA stands for manual vacuum aspiration. So this is where the doctor conducts the procedure. They remove the retained product of conception. We have our syringes here, and then down on the trolley we have vacuolators. Sometimes our patient goes in PPH, or let me say, for instance, if a patient starts losing so much blood, we have to put up IV lines just to just for them to be stable. Okay, and then here we also have syringes and then cannulas also. And then we have our lignocaine. We use the lignocaine for cell block. When the patient, when the doctor is removing retained products, the patient goes through so much pain. So they have to inject lignocaine there just for to numb the muscles so that the patient cannot feel so much pain. If you check this side, this is where the patient lie. They lie on their supine, and then they put their legs here so that they can open up nicely so that the doctor can be able to conduct the procedure. There is our sonar machine. The doctors will always make sure after conducting the procedure, they have to use the sonar machine just to check if there is any retained product that are left after the procedure. So before procedure, they have to use the sonar machine to check the retained product. After the procedure again, they have to use the sonar machine just to check the retained product if there is any left. So this is where some of our instruments, the instruments that need to be sterilized, they are in this pack. So every pack will only be used by one patient. If they are done, then they have to take it back for sterilization. This is just for light. Okay, so we have three basins there, those boxes there that you can see. They have instrument, but they have different water in it. Instrument, when the doctor is done using a certain instrument, they have to rinse it. After rinsing, and then they have to put it in Sidex.
Sister Mujanima explains that the cases of abortion recorded at the hospital depends on seasons, and they have a roster which they share with Katutura State Hospital.
We have a roster for admission, of which we share with Katutura Hospital. So there are days, there's a roster already with dates and the ward admitting for that certain day. So whenever sometimes you will receive round about 2 patients, sometimes you receive maybe 6 or 8 patients. It depends day by day. But in most cases, when, let me say, for instance, it's December, like March, February, we are expecting a high number of patients that are coming in with an incomplete miscarriages or inevitable miscarriage, whatever kind of miscarriages. I don't know why. Maybe it's because of festive seasons, but like mid-year, you hardly get a lot of number of these cases, but maximum number that we can get, they can go around until 12 or 10 per day.
In the past, doctors and nurses first needed to report a suspected botched abortion before they could offer help. But as lives are at risk, healthcare workers now prioritize saving the women seeking medical services. Sister Mujanima explains in which instances police are informed.
It doesn't happen more often because, it's not the responsibility of the doctors to call the police. For them, they only treat. They give the proper treatment that the patient needs. But we encounter cases where, let me say, a patient comes in with a height of fundus that is 28. There will be questions that why this big tummy, but there is no baby, no placenta, nothing. In such cases, you find some doctors, yes, they will involve the police. Some they will involve probably social worker, and then social worker will take it until gender. Like, let me say, for instance, it's just an example. Like last year, we got a teenager that came in with No, she didn't come in with a placenta, but the tummy was so big. You can literally see that maybe this is 32 weeks. This was 32 weeks, but there was no baby, there was no placenta. So the doctor has to question and question, but we didn't get any answer from that patient. So what the doctor did is involve social worker, involve the psychologist, and later on involve um, the police officers. But we hardly get these cases because for them is to treat. Even if they say this is an illegal abortion, it's not it's not up to, I mean, it's not really a case, you understand? Because for them they focus more on treatment than these legal documents and all that.
The doctors and nurses explain that patients who come in with incomplete miscarriages and have suspected cases of botched abortion are encouraged to take family planning after the procedure. But how open are these women to using family planning?
Family planning wise, we are fine. Yeah? We almost have every type of family planning. But the challenge that we are getting now, like in the gynae department, is most of the patients, they don't want family planning. Okay, we try to explain, we try to give health education, because you find out that somebody doesn't want family planning because of whatever other people have said in the community, the way they understand it. We try to give health education, the benefit of family planning, but still, majority of our patients, they don't prefer family planning at all, because we prefer before discharge of this type of patients, at least every patient that we are discharging should be on family planning. But you'll find out, like, in a 50% of patients that you are discharging per day, it will only be maybe 10% of patients that will get family planning. We have a challenge, a very big one.
It is on the eve of Valentine's Day. I am at Windhoek Central Hospital Gynae Ward. Health Ministry Executive Director Ben Nangobe has given me permission to film inside the hospital. Consent should be obtained from the healthcare workers and the patients themselves. The nurse on duty tells me they've made some admissions the previous night and this morning for incomplete miscarriages. One patient was being prepared to go to the manual vacuum aspiration room for cleaning. She was evidently in pain for the news crew to approach her for filming.
So, when I went there, I had to wait for the doctor until 11 o'clock. That's when I went back home. So, I was bleeding. Then I had to go to the sauna, and she told me that the baby was fine. So, that eventually the bleeding would stop. Then I went home. It stopped, but then started again. That's why I had to go back last night.
And then when you went back, what happened?
When I went back, then I got help. The doctor examined me, and I'm here.
They sent you to Windhoek Central.
Yes. Okay. How far along was your pregnancy?
She's a mate.
Okay.
Is this your first baby or do you have?
I had 3 babies, but I had a miscarriage before.
Okay.
Starting 2018.
Mm-hmm. I'm so sorry to hear that. How old is your last boy?
Mine,
Your last one?
she's 6 weeks long.
No. Boy or girl? First, this is girl. Oh, then first. Oh, the same things. Also, you have 3 girls. Yes. Okay. And they live with you?
The first one was me and my grandma. The second one was my father. And the last one was my aunt.
Okay. They have the same fathers, all 3 of them?
Two of them, yes.
The-
Except for the last one.
Okay. I'm so sorry to hear what happened. So what did the nurses say is going to happen now?
Um, I'm still waiting there. And yeah,
You're waiting for? What did they say? Like what did they say is a problem?
and the particular, she said that I was pregnant, but the baby is no longer there. So they have to send me here to be cleaned. Only.
And then when you came here, what did the nurses here say?
They just gave me a vent. So I'm still waiting.
They haven't said anything. They haven't examined you or.
But they did.
Mhm.
They did. So I don't know what's going to happen next.
Okay. All right. Thank you so much for talking to us.
Dr. Cornelian Defawn speaks about the different types of abortions.
Okay, I don't want to be too medical. Broadly, we have the medical abortion and the surgical. The medical is that you just take a tablet, you take a medicine to terminate, while surgical, there is an instrument involved in a short procedure. But any of those abortions, once they begin to have complications, we begin to give them other names medically, like incomplete abortion, where is a part of that product of conception is left inside. Then we can have septic abortion, again common with these illegal abortions because the environment where it was conducted wasn't good enough. So with the instrument I talked about, it might not even have been sterile, and then it brings in infection into the uterus, and then you get septic abortion. And you can have what they call threatening abortion, which again, if somebody has tried to terminate and it has not, should I say, it hasn't been fully effected, it's like it's coming on, and it comes to you that is a healthcare worker, you might label it as a threatening abortion. Yes. And there's also, this will go into the area of a miscarriage, which is a bit different from abortion. So broadly, you just have the surgical and the medical.
In June 2020, calls for legalizing abortion in Namibia intensified. But what are the barriers preventing reform to legalizing abortion in this country?
In places where it's restrictive, it's an absolute ban, regardless of circumstances. Whereas in Namibia, it's not an absolute ban. There are circumstances in which abortion is legal. Incest, when there's severe deformities to the child, issues of rape. So it's not one of the worst in the world.
Maria and Vicky share their experiences of the abortion methods they used to get rid of their pregnancies. Please take a look at what the two women explain.
I don't know what it is called, but I looked up for numbers, with this whole social media, and I got some numbers, advertisements. I called them and told them I was pregnant, and then they asked me how long was I, and I told them, and they said they were selling pills, and then with the period that I told them that I was pregnant for, they told me I had to pay a certain amount of money for me to get the abortion pills.
Traditional medicine.
So they had a cutting in the location. I don't know. They say it's like apparently a green stick. It comes. That one mostly is fatal. Most of the patients, I don't know. They don't know. Most of the patients that we had mostly ended up with serious complications because of that. Because when it stays inside, it causes infection, and that infection is the one that causes either a serious sepsis or we had patients, maybe 2 or 3 cases that ended up in a uterus being removed. In someone's, it was just the first baby. Then the uterus is removed. Anyway, we also had a case where someone just put a normal stick up there. And then somehow, maybe it was not put in properly. It didn't go through the cervix, so it went through the meat, and then it got stuck. Now it has to come here to be removed. Those are the only 2 instances. But I think most of them are trying to find more safer methods that they can use rather than using those methods. They say a green stick. It's like a piece of a branch or thing that they take from a specific tree in the location. So maybe they buy it, or maybe they just take from any tree, then they put it up there. Maybe they have someone in the location that knows how to put it in, and then when it comes, it removes almost everything. But most of the time, it causes infection to that specific patient.
In June 2022, calls for legalizing abortion in Namibia resurfaced again and intensified to a point where a petition to amend the law to increase access to legal abortion in Namibia was signed and has attracted over 60,000 signatures. The authors of the petition proposed that the right to access legal abortion should be accompanied by education relating to sexual health and reproductive rights to prevent unwanted pregnancies and baby dumping. Attempts to liberalize the law on abortion have been met with strong opposition from religious groups and some women's groups and politicians as well. Although abortion is illegal in Namibia, in the 1 week which I visited the 2 largest hospitals in Windhoek, they record daily cases of at least 12, on some days fewer, and on other days more cases are recorded. The nurses and doctors explain further on the dangers to abortion.
And we've actually lost them, died from that severe septicemia. So what is septicemia? It's like having bacteria in your bloodstream. Yeah. And then we've also lost the ones that bled too much, particularly the surgical. Some of these people are just trying, it's like they're desperate to end this pregnancy. So they take instruments, they don't know the anatomy of the what we call internal reproductive organs. And then they can puncture the uterus. Puncturing the uterus can cause severe bleeding, what we call hemorrhage. And when there's a complication from illegal activity, what happens? People don't just, they're looking for corners, how to enter the health system. Before you know it, delay. And then they bring the person, we say paper white, they bled out. These are very severe cases that contribute to maternal mortality. The less severe ones, you are able to manage the infection and the girl goes home. But it has long-term sequelae, aftermath, like blocked tubes, which if you stay alive, and I often say, which girl is not beautiful? Later, they are going to find Mr. Right. They are going to do that wedding. Then the tubes are blocked. No pregnancies. They now start to live another stage of pain. Another stage of pain completely. Then some, if they do the surgical abortion too frequently, they overdilate the cervix. Now, imagine our parents of those days could carry 9 pregnancies. The pregnancy doesn't just drop. Now, with frequent surgical abortion, they weaken the opening. So that sphincter is not there. By 5 months, miscarriage. So though the miscarriage now is natural, but the primer is the previous surgical abortions, because instruments were forcing that passage to open. You get it, oh, now nobody had that I did an abortion. You get pregnant again, you go there, you get again 3 times. You weaken the system.
One thing I would want to caution against always is really looking at abortion in isolation. And I think that's part of the problem with this topic. Everybody looks at it in isolation. I think once there's an unintended pregnancy and there's somebody considering an abortion, many other things went wrong. So let me be clear on one thing. Abortion doesn't resolve issues of unwanted pregnancies. Even where abortions are legal, there are unwanted pregnancies. Abortion doesn't solve the issue of reckless sexual behavior. And the reason it doesn't solve that is that it is one of many options that and solutions that should be available. It cannot be the only one. So we must talk to young people about sex. We must engage issues of sexual violence and coercion when it comes to particularly transsexual relationships. We must make family planning available. We must make contraceptives accessible to those who need them. We've got the statistics of how many young people younger than 13 years of age who are giving birth. And these statistics are uncomfortable for me. And what makes me uncomfortable is all of the tools to reduce unintended pregnancy in adolescents, whether it's sex education, whether it's contraceptives, all of these things are taboo and wrong, and against some or other religious or cultural belief system. So how exactly do we want to prevent unintended pregnancies? Because surely we also saying we do not want teenagers to be pregnant. We know they're having sex. The only way to reduce this is to talk to young people, delaying your sexual debut, which I believe in from a health perspective. I don't think from a health perspective we should encourage young people to be having sex. We should be encouraging them to delay sexual debut. We must be able to have conversations around what's currently happening in Namibia, where abortion is illegal, where we see the statistics and we can see it's happening. A lot of these young women are looking for post-abortion care. So there's either been an inducement of a pregnancy. Our healthcare workers are dealing with this on a daily basis. So it is happening. It is a reality. We can't deny that. So to prevent us getting to that stage, because I wouldn't encourage any person to go against the law of your country, I would rather have a conversation with young people about delaying sexual debuts, around safe sex, and having frank conversations. That's really where my focus is. It's not necessarily on abortion.
Based on facts, healthcare workers, civil society, and Ms. Gengos share their opinions on restrictive religious and cultural views on abortion in Namibia.
No, I think people are free to have whatever cultural or religious view that they have. I'm not a critic of people who really believe in what they believe in. But as a Christian myself, I'm also very conscious that even in countries where abortion is legal, the moral decision of whether to perform it or not still resides with a mother. I'm not obligated to have an abortion just because it's legal in a country. So the moral decision still needs to be made. And that moral decision also needs to be made in countries where abortions aren't legal, where they continue to happen. So I would really encourage people to live by their Christian and their religious and cultural beliefs. What we should always, however, be careful of is imposing our beliefs on others, because the circumstances that require certain decisions to be made may exist outside of religious and cultural belief systems. So maybe if anything, sometimes for me, it's about health care. It's about women's health, and it's about what's best for that woman in that moment. And what's best for me may not necessarily be best for somebody else. And that's how I look at it. If something is against my religious belief system, then what it means is I shouldn't do it.
In Botswana, according to a report by the United Nations Population Fund, complications from abortion remains a leading cause of maternal mortality, accounting for 23% of all maternal deaths, and it's consistently more than double the Sustainable Development Goal target of a maximum 70 maternal deaths per 100,000 live births.
First things first, I should probably say I'm pro-abortion. I know some people say they're pro-choice, but it's not just about the choice for me. I think abortion should be one of the biggest choices that everybody has.
People who live in the margins tend to often find themselves not able to vocalize their injustices or inequities that they experience. And so I think this has been quite integral in recognizing that many women and girls live in the margins, particularly those who have to turn to backdoor abortions. And why do I say this? Because countries like Botswana that have inherited certain colonial laws still have very restricted provisions where abortion is allowed. And I think for me, it's recognizing that it's largely structural. It's structural because there are harmful gender norms that are perpetuated, not just in communities. Also noting that Botswana is a dualist legal system, so we heavily rely on community structures that include the customary court, our kotlas. And so recognizing that these harmful gender norms permeate beyond just community, even beyond customary courts, and even national governments, and essentially globally. We're recognizing how patriarchy, privilege, and power is often used as a tool to police the bodies of women and girls in their diversity. And I think for me, what's important is in recognizing that beyond just harmful gender norms and legislature, is recognizing that there are certain practices, traditional practices, idioms, language, and I think even to some extent gatherings that tend to obviously regress. And so what does that then mean? It means that you aren't allowed to have conversations around abortion. You aren't allowed to have conversations around some of the complications that come with pregnancy. And so I think for me, it's very important just recognizing that essentially it's an individual who has to go against all odds to have to seek some form of assistance with regards to abortion.
We talked to Maria and Vicky, who share their experiences of the abortion methods they used to get rid of their pregnancies. Here is what the two women say.
First, they gave me 4. And first they gave me 4. They didn't work because I had to go. They just told me what to do. I had to go in and set the pills myself. And then they said after certain hours, it should start showing signs of me being in labor. And then I went the whole day. It didn't work. So I called them. Then I said there is nothing that is happening. I'm just normal. Everything is just as it is. And then they said, no, maybe you miscalculated. So here's what we're going to do. You were just going to add just a little bit of money and then we give you a higher dose. And then they came, they gave me the dose and they went back. So I used the higher dose and then that's when I started to feel something. Maybe a few hours later, maybe 3 or 4 hours later, that's when I started to feel some cramps, the pains. That's when I could start feeling that now I'm in the process of whatever is inside of me, of it going out.
Like Maria, Vicky too had a backstreet abortion, but she did not use tablets. She used a traditional method. No medical care was given to her. Vicky, who is now a beautician, aborted in her early 20s. She is now 46 years old, yet she remembers the incident like it was yesterday. She was raped by her uncle. Life was tough for Vicky, and her uncle's wife took her in to look after her. The uncle took advantage of the situation and sneaked in her room and raped her. Few weeks later, she discovered she was pregnant from the rape. She could not tell anyone but a friend who offered to help her terminate the pregnancy. She aborted using a branch of a tree. She does not know the type of the tree that was used, but it was a stem same length as that of a matchstick.
She just took a branch of a tree. She knows the type of a tree, I don't know. And then she told me to insert it. Yeah, it's just a small stem that you just measure the matchstick and then you insert it. Yeah, because the reason is the womb doesn't like something smelly. So once you insert it and it smells that one, it will open the mouth. Yeah. I just insert it like in the morning, and then when I woke up tomorrow, the things were already in the passage to come out. So in the night, I was just having the pain.
Yeah.
Afterwards, I just told her that the things worked, the things are out, and then she gave me again the other medicine to drink to clean the womb.
The Namibian government has ratified the African Charter on Human and People's Rights on the 30th of July 1992 and the Protocol to the African Charter on the Rights of Women in Africa the 11th of August 2004. But has the country made progress when it comes to the Maputo Protocol?
I think services should be accessible. And the challenge when we have commodity shortages on family planning, there are possibly immediate consequences. If somebody is seeking a particular service because she doesn't want to fall pregnant and the product or the commodity isn't available, we'll be seeing that person 9 months later looking for additional services. So I think we should be able to provide the services for women as they seek them, particularly when it comes to prevention. I'm a big believer in prevention. When we start talking about things like abortion, it's because we failed on prevention. So where it's possible to provide the solutions that are needed early, they should be available. Although the current commodity problem has a particular problem relating to procurement issues. And what I do know is that state facilities generally are quite good at providing commodities, but in the last year, it hasn't been great because of a particular procurement-related issue. But just on the Maputo Protocol, and maybe unrelated, but also related to this topic, is in political science, there's a word called, or there's a concept called the Overton window. The Overton window is about legislation being able to pass when there's a certain level of acceptance from the community, from the people themselves. And what we may be seeing globally in many discussions is a backlash towards legislation or policies that communities are not ready for. So it is important to check where the Overton window's opening is. Is society ready for abortion or not? Don't push things that societies are not ready for, because there is a backlash, there are consequences. And the question is really out, is Namibia ready or not? If it's not ready, don't push it. If it's ready, then take a decision on whether it's the right healthcare decision. I look at it purely from a healthcare perspective. I look at it from a woman's health perspective, but I'm always cautious not to impose my views on other people. And I think this is probably a message to everybody. Whatever our personal views are on the topic, we should be careful, particularly when we have public trust and responsibilities, to impose whatever our personal views are. It should be evidence-based. We should be looking at the statistics. And this particular topic is about healthcare. What are healthcare professionals saying? What is the experience of our healthcare framework? What are doctors saying? I'd be very interested to hear what doctors are saying. I'd be very interested to hear what women themselves who are affected by it. I'm hitting 50 soon. This is not a topic that affects me biologically. It's a topic that affects me maybe as a Christian. But do I have really the ability to impose my views on young women whose lives, experiences, and realities are different from mine? The answer to myself is no. And we should all ask ourselves that question.
Illegal abortion is most common in developing countries. Developed countries, as the word goes, they've gone through it all, if you would say so. They've gone through the challenges and they've come to understand the importance of legalizing abortion.
I think, first of all, like I said, people change their minds
Yes.
when they get pregnant. Either they not planned it, or they planned it and then along the line they changed their mind about carrying the pregnancy further. So basically the first step people probably do is to research. How do I terminate a pregnancy? Or to ask friends, how do I terminate a pregnancy? So there's a whole lot of theories, and some true and some false, that we find in the streets. Okay, some people go drink Fanta mixed with salt. Some will say, there's this lady there who will give you whatever. There's this, so there are this guy who sells these tablets. So you will find out that most people find different routes to do these illegal abortions.
But when it comes to a clinician, a medical doctor, what are my views? I might say that I will stand both for and against, in a sense. You know, we deal with the society, and you can hardly have the entire society believe on the same thing. You will have those who are for and those who are against. When it comes to managing a young girl that has gone through illegal abortion with complications, you wouldn't want to lose a life. And at that point, you will be saying, why do they not legalize? Just so that people can obtain abortion in a safe environment from skilled providers.
I'll probably give you two perspectives.
Yeah.
Okay. As a Christian perspective, I think it should be allowed. All right. As a doctor, I think this is personal to me. I think women should be given choices of what to do about their bodies, what to do with their pregnancies. Either way, whether we allow it or not, whether we legalize it or not, people will still find ways to do abortions. So, yes.
For me, as a clinician, it's not my place to judge or condemn a young girl to death. So, restricting abortion is not always going to be the best, because while we are trying to save the life of the unborn child, we may actually be killing the mother. And a mother is not a mother for that pregnancy that she wants to abort now. If she could abort safely, she might just become a mother for another child tomorrow.
It wasn't very easy for me. I gave up a lot of things. I adopted certain behaviors. I started drinking. I started smoking. I started abusing drugs. I was even negligent with a lot of things. Even my own family, my own children, my own siblings, everything. Because I just felt, I don't know how I really felt, useless maybe. And I was just draining in this whole pain that even if I want to try and explain it to the next person, or no matter what I will say or how I will say it, there's this whole nip that even today, even if I talk about it, I feel nobody will ever understand. And yes, maybe they can just be me. Just maybe. That's how I felt.
No, I just began to hate men, that's all. any man that comes closer to me, I just feel that men are the same. I can date, but it doesn't last because I don't have any feeling for men anymore. It's just this hatred, just the hatred in me. Even when the men come closer to me, like, I don't know how to explain it, but I don't feel them anymore.
Yeah. Whether one likes it or not, there are risks involved in backstreet abortion. The healthcare workers explain some of the dangers these women face, both physically and emotionally.
Okay, let's start with the physical consequences. All right, let's say because this is illegal, probably 60% of women will find themselves doing abortions in an unsafe way. So the first thing that you should know is when done in an unsafe way, people contract infections in their uteruses, in their tubes, which might make them not give birth in the future. And then for some, they can bleed quite a lot during the procedure, which might result in them being hospitalized, which might result in their uterus being taken off, like during an operation, because it will be damaged. So that's the physical consequence of illegal abortions. And then we come to the emotional part. Yes, some women will live with regret after doing an abortion. Maybe they've gone for a sonar, they've seen their baby in a 3D or on a picture, and then this can stick in their minds. Guilty can still remain for a long time for them. And some will need counseling after that, so it's not easy.
So emotional stress is there because remember we start with basic primary school and people fall by the wayside, either because there was no money to go further, and the next thing is marry. It's always starting like that. Hey, here is a man, marry. You sleep, you get pregnant, no lobola paid. As time goes on, you find your classmates that were lucky. Either there was family planning or there was a complete family, mother and father, that were there guiding and helping. And now your classmate is a lawyer. Your classmate is a doctor. Your classmate is a journalist. Your classmate is a school principal. Your classmate is wherever, successful. And you are stuck with 3 children, 4 children, to many fathers that you don't even see. So there is that emotional pain of not having had the opportunity to hear about family planning, to access it freely.
What are some of the contributing factors to unsafe abortions in Botswana? And what does the sexual reproductive health care landscape look like in the country?
I think the truth of the matter is that Botswana has been, because of our HIV pandemic, we've been very aggressive about sexual reproductive health rights. But the gaps are definitely there and they are big, right? You talk about access to birth control, for example. Some clinics have it, some clinics don't. And I mean, that's a problem that the healthcare system in Botswana is facing in general. Medication just isn't in the clinics, or the options are limited. Clinics are not youth friendly. The nurse is your aunt Simangman, right? You realize, this person might tell my mom that I was here. You're not really sure if you actually have doctor-client privilege and all of that. And so young people don't go to clinics. I mean, but also just knowledge, right? A long time ago, I feel like we were a little bit more aggressive with our family planning education. And it hasn't been a priority in the past couple of years. And so young people don't know what they have the rights to and what they can ask for, 1. 2, there are also a lot of myths around birth control, right?
So I think, yeah, it's the first is really speaking to harmful gender norms. So what does it mean in the context of, needing that health? I mean, abortion is a health right, right? And so in a country like Botswana, where socioeconomic rights are not justiciable, so essentially the right to health is not guaranteed in our constitution, that means that, women and girls are often have to resort to unsafe abortion or backdoor abortion. I think one other element that's quite important to recognize is the fact that even from a policy framing perspective, the very same bureaucrats who design some of these policies and procedures do not believe in abortion as a human right. And I think it's very important because then that means those who have to practice in health facilities then don't obviously share the same beliefs as many activists do. And I think this is important because we have so many people that are coming back and saying, obviously, it's not allowed, it's not permitted, and there are many other determinants, inclusive of the ability to actually seek those services outside the country or in some private facilities where they know that they have some element of social or economic power to get them that kind of access. And so I think it's a poverty issue, it's a gender disparity issue. Even when we think about some of the other community structures, such as social workers, who know full well that this is one of the taboo issues that they'll never touch on, especially in instances where there is defilement, or especially in instances when it's allowable by law. It's still very, very difficult because there's so many elements that mask it. And I think the biggest underpinning factor of this is the stigma and discrimination that's attached to it. There's an element of shame. There's an element of not only just feeling embarrassed, but also the inability to get the kind of information that you need because someone will already rebuke the option or the possibility for you.
Yes. So one thing I want to make clear, BFRE has got nothing to do with abortions. We often get misunderstood on that point, and I don't want that point to be misunderstood in this conversation. And even when we're talking to young people about sex, the frank conversations, we let them lead the discussion. We listen to what they have to say, and then we give common sense guidance around just what I talked about now. Our fundamental point in BFRE, when we're talking to young people about sex, is the benefit of delaying a sexual debut for a young person. We do not believe that a young girl should be carrying a baby and books. We strongly believe it should only be books. We do not believe that adolescent boys should be fathers. We believe that their focus should be on their education. Parenthood for teenagers is not something that any of us should be promoting or encouraging. And that's the reason why we speak openly and provide services in relation to non-judgmental sexual education, where we allow them to talk, and we also give our views from a non-judgmental perspective. The second thing that we do, we have an adolescent-friendly clinic where we do provide contraceptives to young people. We speak to them about the advantages, the disadvantages. We give lots of adolescent-friendly related methods. Implants, for instance, are very popular. We do that for free because it does enable young people for quite a period of time not to have to worry about falling pregnant. But then we remind them the problem is not just pregnancy, it's also HIV. Adolescents on this continent have, particularly adolescent girls have 3 times a higher chance than contracting HIV than their male counterparts of their same age. This is a problem for me. And so we don't just talk about avoiding pregnancy. It's also about avoiding STIs. It's also about avoiding HIV and the consequences that has. It's also about the consequences, both physically and mentally, about early parenthood, particularly in low-income environments. And then lastly, the point that I have, which is something that I struggle with personally, is our laws are restrictive only for the vulnerable and only for people who can't afford certain services. The challenge that I have is there must be equity in our law. If our law is such that the wealthy can afford to take their children to South Africa or convince doctors even locally to assist their kids, then we're saying that these laws that we're talking about from a moral perspective are only applicable to those who can't afford to get things done elsewhere. And this is what we warn young people, is that early parenthood, it almost entrenches you in poverty cycles, because now you need to leave school, and your ability to go and become economically productive becomes reduced by the obligation to look after your child. And the statistics that are showing us, particularly in some regions, is that often when you have a baby early, by the time you're 21, the likelihood that you have a second baby is high. And I'm a big proponent of people having children when they want to have the children, and when they're ready for children. Parenthood isn't a decision that we should force anyone. So it's not only about the right to life, it's also about the value of life. I'd be an incredible hypocrite if I was to say to somebody, to be interested in making sure that somebody has a baby, but I have no interest in the quality of life of that baby or assisting the person. So we must also really speak about the structures that we put in place to assist, particularly young people who go into early parenthood. We have a lot of discussions about all types of things, but I'm seeing very little services being provided to young people who are parents. And what other alternatives there are. I know that there's alternatives, for instance, for adoption, and to send children to children's homes. It's something I have deep concerns about. I don't believe any child should be in a state facility, in a state orphanage. That should be an absolute last resort. Children need to be loved, and they need to grow up in loving and caring families.